So for patients with earlier stage colon and rectal cancer, stage 2 and stage 3 in this instance, who undergo a curative surgery, traditionally we offer some of those patients chemotherapy to help decrease the risk of recurrence. However, we know that chemotherapy has side effects, especially neuropathy, which can in some cases become permanent. We know that we're probably over-treating a fair amount of patients. So can we be smarter? Can we use more than 19th century technology, which is what we get in our pathology report, to help guide us in terms of who should get chemotherapy, who should not, and if patients should get chemotherapy, how much chemotherapy and for how long? Newer technologies are helping to answer this question, and one of them is circulating tumor DNA. This is a test of what we call minimal residual disease. Can we detect the presence of cancer after a curative surgery when it shouldn't be there? And if patients have minimal residual disease, we think they are going to develop recurrence of their colon or rectal cancer at some point. So one of the technologies is circulating tumor DNA. This is a blood test, which is fairly easy. We also use the patient's tumor specimen, do DNA sequencing on it, and then a company creates a personalized blood test for the patient. We can then use that to see if folks have residual disease following surgery, and that may inform who should get chemotherapy or who should not, although we need more data to help make that decision. But it also helps patients know what their likelihood of recurrence is. Historically, patients need blood work, CAT scans, visits through 5 years following their surgery, and then can really be told that they're really cancer-free and that their cancer will not recur. We hope that this technology will be an earlier signal and help patients know their likelihood of recurrence sooner in their disease course. And that may guide their treatment and also may alleviate some of their anxiety. So the other use of circulating tumor DNA is a slightly different test where we call it like a liquid biopsy. And this is where we take a blood sample from the patient and do complex next-generation sequencing on the DNA in the blood, and we can actually collect circulating tumor DNA that is being shed from known sites of disease and then be able to maybe guide patient selection for different treatment options based on that report. Historically, we've needed to do tissue biopsies, so an invasive needle biopsy to the liver or somewhere else in the body, and then to do deep tissue-based next-generation sequencing on the specimen that can take several weeks to come back. We hope the blood is less invasive, can give us most, if not all, the same information from the tissue, and we can often get the results back within 2 weeks. The other use for this technology is resistance. So we're using more and more targeted drugs, and when we develop targeted drugs, we often develop resistance. And if we biopsy a site in the body that may not have that resistance mechanism, we're not learning why other areas in the body might not be responding to that targeted drug. So using the liquid test, we're able to pick up resistance mechanisms, which we may then have another drug that we can use to target that resistance mechanism. The docs in the lung cancer world have been using this for quite some time because they have very targeted drugs that develop very well-known resistance mechanisms. Using the drugs that we use, we're still learning what those resistance mechanisms are, and by doing more of these blood tests, we're not only learning, what's out there, but also what we can target with new treatments.